we'll start the second panel on global bioethics in practice. And this session, we will bring to life how compassion, cultural wisdom, and ethical dilemmas are navigated at the bedside and across healthcare systems. So let us now welcome the first speaker of this panel, Mr. Gerald Lee, Chairman of Bodhinyana International Foundation, Hong Kong. He will be presenting on what matters in spiritual care for end-of-life patients, a Buddhist perspective. Mr. Lee, the floor is yours.
Thank you, Grace. Good morning, everyone. As a former Buddhist chaplain, I served at Queen Mary and Grantham Hospitals, two public hospitals affiliated with the University of Hong Kong's Faculty of Medicine. Today, I will share some bioethical lessons I learned from my service in those two hospitals, especially those rooted in the Buddhist teachings, which anyone can apply when caring for end-of-life patients. To do this, I will share the experiences of two former patients for whom I had the privilege of providing spiritual care as part of their palliative treatment. I'm grateful to them and their families for their trust and permission to use their real first names. Gun Wei is a 63-year-old Chinese man who sought medical care due to severe fatigue. A father of two adult children, he worked as a truck driver before his illness. After a series of medical evaluations, he learned that he needed a liver transplant. During my initial visits to his bedside, Gun Wei's eyes were filled with tears. Although his children and his ex-wife were willing to be organ donors, he declined, fearing they might risk their lives for him. Fortunately, he received a liver from an unrelated donor, and despite a challenging medical journey, he eventually stabilized and was discharged home after 5 months. Gun Wei's family members are Christians. They place a Bible and a standing cross on his bedside table. While Christian chaplains visited and prayed for him, he also welcomed my Buddhist colleague and me. On days when he felt better, he was talkative, discussing everything from his favorite foods to his improved relationship with his daughter. A few times, I was touched to hear him leave gentle voice messages on her voicemail. Gun Wei was often humorous as well. We sometimes shared jokes and laughed so loudly that the doctors and nurses might have wondered what was happening. He often joked that if he had known my colleague and me earlier, he would have become a Buddhist because, in his words, "You guys are more embracing of people of other religions." When we left his bedside, we always said, "God bless you," reminding him of the love he has received from his Christian friends and family. Our service was not intended to convert patients to Buddhism, but rather to care for them by listening and being present. Perhaps for this reason, he trusted us and even referred us to visit some of his fellow patients whom he had befriended, which we did. Gun Wei shared with me a valuable insight. During his hospital stay, his greatest suffering did not come from the deliberation about undergoing surgery. Instead, it arose from the profound loneliness caused by separation and isolation from his loved ones and close friends. This feeling was intensified by his desperation to survive. "Your visits mean a lot to me," Gun Wei repeatedly told me. His words reminded me of why we visited. There is a boundary that separates presence from absence. Spiritual care transcends that boundary, creating a space for comfort and solace. Gun Wei and I have kept in touch since his discharge. On one occasion, he insisted on treating my colleague and me to lunch as a gesture of gratitude. During that lunch, he asked if we could join him to visit Henry, another organ transplant patient we all knew, who had been hospitalized again. We agreed, and the four of us chatted like old friends for over an hour by Henry's bedside. Unfortunately, not every patient like Gunwei survives a serious illness. Tanusha was a 54-year-old tax attorney from Sri Lanka. She moved to Hong Kong after marrying Smith, a marine engineer who has been working here since 2000. The couple practiced Theravada Buddhism, a tradition common in Southeast Asia, but not widely followed in Hong Kong. Their 18-year-old son, Kevin, was studying bioinformatics while participating in a NASA project at a university in North Dakota in the United States. Tanusha was diagnosed with breast cancer. Although the treatment was initially successful, the cancer returned and spread to her lungs. Although Tanusha regularly listened to Dharma talks online, neither she nor Smith knew any monks or nuns in Hong Kong. When I offered to arrange for one to visit her, they accepted with gratitude. Knowing Tanusha's prognosis was poor, I quickly called Venerable Dharmajoti to see if he could come to her bedside. The Venerable is a Chinese-Malaysian Theravada Buddhist monk and professor who taught in Sri Lanka before teaching in Hong Kong. He's fluent in several languages, including Sinhala, the most widely spoken language in Sri Lanka. Despite his busy schedule, he kindly agreed to visit Tanusha the next morning, arriving at the hospital with two Bangladeshi monks studying at HKU, one of whom is fluent in Sinhala. When Smith gently patted Tanusha's shoulder and whispered that the monks had arrived, she slowly opened her eyes. Upon seeing them, she smiled and tried to bring her palms together, a traditional gesture of respect towards monastics, but she was too weak to do so. Venerable Dharmajoti softly waved his hands to indicate that the formality was unnecessary. The three monks then helped Tanusha reaffirm her faith by taking refuge in the triple germ and observing the 5 precepts. She closed her eyes and listened attentively to their words. They then chanted the Karaniya Metta Sutta for her blessing. Finally, Venerable Dharmajoti asked the Sinhala-speaking monk to deliver a talk on impermanence before departing. The monk's visit meant the world to Tanusha. First, the rituals were conducted in the tradition she was most familiar with. Secondly, the monks were able to speak with her in her native language while she was away from her homeland. When I returned to Tanusha's ward after seeing the monks off, she spoke to me in a voice that could barely be heard. Smith conveyed to me her last words, "I feel good, thank you." She passed away shortly after midnight the same day, just a few hours before her son arrived from the US. A few days later, Smith, Kevin, and I gathered together while awaiting Tanusha's body being returned to Sri Lanka for cremation. This was my first meeting with Kevin. Throughout the time, the quiet yet empathetic young man gently placed his arm around his father's shoulder, providing comfort as Smith mourned the loss of his wife. Shortly after Tanusha's passing, at Smith's request and according to Sri Lankan custom, I organized a Theravada Buddhist service at Venerable Dharmajoti's temple, which included a Dharma talk. Before it began, I told the Venerable that Kevin had been unable to see his mother one last time before her death. In a compassionate gesture, the monk shared his talk that while teaching in Sri Lanka, he too had been unable to see his mother in Malaysia before she passed away. He recounted receiving the news of her death during a class when someone handed him a note. Despite having 10 minutes left, he remained composed and finished his lecture before contacting home. Venerable Dharmajoti comforted Kevin by assuring him that he was not alone in his grief. Like Gunwei, Smith has stayed in touch with me. Recently, he invited me to participate in a dana, a Theravada Buddhist event where food and essentials are offered to monastics. It was held to honor Tanusha on what would have been their 25th wedding anniversary. Meanwhile, Kevin made his parents proud by graduating magna cum laude and will pursue postgraduate studies in cancer research at a university in Minnesota. What these two lived experiences show is that every end-of-life patient is unique and special. Although some recover, many do not. However, they have all demonstrated to me a core teaching of the Buddha, that nothing is permanent, including our health, our lives, and the people and the things we love and cherish, no matter how much we treasure them. We experience suffering due to our attachments. When the people and things we love are gone, we feel a sense of loss and long for their presence. If we recognize that life is fragile due to its impermanence, and if we accept that life is precious because it is transient and momentary, we need no longer suffer from the fear of losing a loved one or facing our own death. Instead, we will appreciate that while pain is inevitable, suffering is optional. We will then learn to cherish time, the most equal commodity shared by everyone, 24 hours each day. We should do everything possible to avoid wasting it. Since time itself is limited, it often slips away unnoticed with every breath. We must treasure it by living in the present, right here and now, rather than regretting the past, which cannot be changed, or worry about the future, which is uncertain. The quality of our future depends on how we choose to live in the present. Living in the present is recognized by most Westerners as mindfulness or present moment awareness, a teaching originating from Buddhism. However, being mindful is not enough. For mindfulness to be meaningful, it must be practiced with both metta and karuna, which mean loving kindness and compassion in Pali, the language of Theravada Buddhism. Metta implies having unlimited friendliness towards all living beings, while karuna signifies alleviating suffering through actions. This combination is called kindfulness, a term coined by Ajahn Brahm, a Cambridge-educated theoretical physicist who has been a Buddhist monk for over 50 years and my Harvard Bioethics capstone mentor. To be kindful, Ajahn Brahm suggests we can ask ourselves the three questions. When is the most important time? Who is the most important person? What is the most important thing to do? His answers are simple yet fundamental. When is the most important time? Now. Who is the most important person? Whoever is right in front of you. What is the most important thing to do? Care. Kindfulness is a universal virtue that everyone can practice with humility, respect, and dignity, which are the foundations of authentic ethical considerations. By acknowledging that impermanence is inherent in all conditioned things, we come to understand that not every illness can be cured. However, we can always care for one another, regardless of our differences, as long as we recognize that we are all interconnected. Interconnectedness means our world exists due to various causes and conditions. Just as a seed cannot grow without soil, water, and sunlight, a baby cannot survive without the protection and nourishment of parents or carers. This realization allows us to transcend our superficial differences and appreciate our similarities. Fundamentally, we are all part of the human family. Our skin colors may differ, but our biological makeup and organs are essentially alike. Therefore, we should always care for, rather than harm, ourselves, other humans, and all living beings. As we witness the devastation and suffering caused by wars and oppression around the world, this may seem easier said than done, but just because this is difficult does not mean it is impossible. With the right attitude, we can see our world in a different light. Of course, reality can be harsh at times, especially when facing death due to a terminal illness. During these moments, What we can offer patients and their families is care from the heart. What truly matters then is love, selfless love, because it helps us accept and overcome the fear and sadness of losing those we love or those with whom we need to reconcile through forgiveness. But we don't need to be Buddhists to love selflessly. Anyone can learn from the wise words of the great philosopher Winnie the Pooh. People care too much, I think, is called love. Thank you for allowing me to share my lessons about selfless love through my service as a Buddhist chaplain. I'm grateful to Gunwai, Tanusha, and all the patients I had the privilege to serve. Thank you very much.
Thank you, Mr. Lee. Thank you.
Grace, if you could give me just 30 seconds, I would like to introduce Tanusha's husband, Smith, who is sitting at the back. Smith, thank you so much for allowing me the opportunity to serve your wife.
Thank you, Mr. Lee. We'll now have Dr. Hui Xiu Tan, Bioethicist and Clinical Ethicist, Ministry of Health in Malaysia. Her presentation is Capturing Values and Persons Amidst Medical Paternalism and Multiculturalism, Ethics Persuasion in Developing Advanced Care Planning Guidelines in Malaysia. Dr. Tang, please.
Thank you very much, Grace, and good morning, everyone. My name is H.S. Tan. Ngô lại lội chi ma lại ma lội sai ngờ so đại ma so lei ho đại家好. Okay, so thanks for having me here in Hong Kong. So thank you to the organizer for giving me an opportunity to share with you on the presence and persuasion of bioethics in developing advanced care planning in Malaysia. So let me share with you a story, the story of Mr. R. Mr. R is a 60-year-old Indian man with bronchial asthma. So he presented with chest discomfort and needed CPR for 4 cycles for cardiac arrest. He suffered hypoxic ischemic encephalopathy, poor GCS, and he was on low ventilator settings but was still breathing. He had other problems, acute kidney injury with hypernatremia, seizures secondary to HIE, and CT scan was showing cerebral edema. So the managing teams were expressing that the goals of treatment at this point was one-way extubation and for best supportive care if family couldn't agree with a tracheostomy. So if recovered, he's likely to be permanently vegetative. His wife separated for 3 years and sons were in agreement with the doctors, but Ali, his daughter, who was closest with him, was saying one-way extubation was wrong and accused the rest of the family of wanting him to die. More needs to be done to rehabilitate him. She preferred tracheostomy and home care. So on further information, Mr. R was a convict and was on home parole, and Ali had been visiting him often in the ICU. So she was the one who actually received the distress call from her father on the day of admission. Mr. R had no advanced care plan. He had not been speaking about his preference about life-sustaining treatment, and the treating team asked the ethics team this question: in the absence of a living will or previously stated preference for life-saving and end-of-life care, ethically, who should be making the decision? Would an ACP program help Mr. R in this case? So as I speak mindful of the groups that I identify with, I make no claims about the best methods of calculation, and the ideas and opinions remain the results of some of the discussion that we have had together when we were involved in the program. So I'm going to cover today the Malaysian context in terms of demographics, cultures, and legal provisions in terms of ACP, why the need for ACP in Malaysia, and the ethical challenges that we foresee, how can bioethics play a role, and a peek into the ACP guideline development and content, especially a focus at the end on social cultural consideration as aligned with the theme of the symposium. And as you know, where is Daima? So, you know, everyone has gone there for shopping, business, and for the food. So I will just share a bit that Malaysia shared her Asian heterogeneous society, values and diversity closer to nations such as Singapore, and also the archipelago indigenous traditions in the Sabah and Sarawak. So being an independent Commonwealth country of 68 years, many legal and public administrative structures follow the Westminster systems, just like Hong Kong, with the Malay kingdom's origins retained through a federal constitutional monarchy. So many public programs and policy making observe Islamic boundaries required by the majority. So Malaysia is multi-ethnic, multicultural, a pluralistic society with some cultural tolerance and not entirely embracing multiculturalism. So we have the dominant group of Malays whose lifestyles and way of living very much defined by the religion of Islam, followed by Chinese Malaysians, mainly defined by Chinese philosophy, customs, and religion. The Indian Malaysians similarly defined by both their cultures and religion, and the indigenous people from various groups with unique customs and beliefs. So truth to be told, Malaysia is so much more diverse than a simplified slide here, as each ethnicity has further ethno-linguistic subgroups and various customs that are defined by the history of migration and their current geographical locations. So on the other hand, the medical culture in Malaysia is still very much paternalistic, like what Dr. Rina has presented also. So patients are not fully empowered to determine their own care, and most decisions are still professionally directed, revealing both the protectiveness and passion of doctors in serving their patients, but also the power differences and the non-confrontational style of patients during medical consultations. And with these gaps of health literacy, there is often this vicious circle of disempowerment for patients to actually have much say in their medical treatment. So a study conducted by the general practitioners actually showed that Malaysian patients wanted more say, and that shared decision-making done right can create confidence, self-trust, better compliance, and improve well-being. So when it comes to end of life, and the first question we always have is, where do we want to pass on? Okay. So this is where, which is interesting, was done by the palliative physicians, palliative care physicians. More than half of the 600 that were surveyed preferred to die at home. But interestingly, when they were asked to actually project and anticipate, would that be happening? Many would say that it may not happen. And because of factors such as interference by family members, pain management that's better handled at the hospital, and caregiver spending, but also interference by medical professionals, among other factors. And thus the question of who makes the decisions, such as in Mr. R's case, when you are critically ill, is the $1,000 question in Malaysia, as it will make a difference if your wishes will be fulfilled. So in Malaysia, a surrogate decision maker is still very much socially rather than legally defined. Accepted decision makers would be legal spouse, close family, a legally appointed guardian, especially for children, and doctors. Rarely an ethics committee or the judge may come in, but generally no. So when a legal statute to ensure an enduring power of attorney and for a legally appointed proxy is yet to exist, the closest act that we have is defining the next of kin, which is limited to patients with mental health disease rather than end-of-life patients. So we have professionally, we have the Code of Professional Conduct, and to some extent the guidelines of consent for treatment that has some provisions that prohibit advanced directives that suggest illegal activities such as euthanasia and termination of pregnancy, but do mention the importance of ensuring the validity and relevance of AD in regards to clinical circumstances when deciding, and the priority for professional judgment in emergency scenario. So there are also professional guidelines that mention on AD, withdrawing, withholding, and end-of-life care, but nothing that defines how those voices, how those values are going to be defined, documented, and smoothly applied in decision-making. So many of these documents that I've shown you do not define what they meant by advanced directives, which we think still likely modeled after ADs in other countries, which is more instructive, specific in nature, with a focus on treatment options, but with the assumptions that patient is well informed and empowered enough to plan in advance. So advanced care planning hopes to actually refocus on the person and their values, wishes, and what matters most, which may still include what a patient may or may not accept in terms of treatment options. It captures the goals and relational aspects a bit better in terms of what makes life worth living and who matters to them. So to counter the confusion regarding ACP and AD among healthcare professionals. So Dr. Richard Lim is the senior palliative physician who led this project at the Ministry of Health, created a diagram. So this with his permission. So he put it up to actually always, when he tried to present it to the decision makers, to the clinicians, about the myth that we have regarding ACP, which includes that ACP dialogues are meant for terminal patient, a DNR form, a legal document, or ACP is meant to persuade patients to choose for conservative care, or it is a tick box checklist exercise, and most crucially, that whatever documented and signed cannot be changed and should be rigidly followed regardless of clinical relevance. So these are all the myths. The rounds of explanation and clarification made at the ministry level by him on these concerns and confusion also led to the public survey of more than 1,000 Malaysians by the Institute of Behavioral Research in 2023 that revealed that even though 1/3 knew about ACP, but majority of them, when explained, felt that it should be available in the healthcare system and was open to discuss further how decisions can be made. So this survey was among the many other research and views that have been published that agreed and support the concept of ACP. So the next stage involved meeting held by the Islamic group to discuss how the objectives of ACP should align with Maqasid Sharia, or the foundation or the goals of Islamic religion, and concluded that patients' wishes can be respected when they do not go against religion goals. ACP is to be encouraged when patient and family have correct and adequate information, and ACP should be discussed based on the benefits and risks of procedures and treatment recommended by MOH and not generalized to all patients and diseases. During the ethics discussion on ACP2 at the Ministry of Health, it was agreeable that ACP is an exercise that extends autonomy, promotes best interests and medical treatment that aligns to the patient's goals and values, and the program of such foster visible, personal, and human connections, showing a true commitment from providers and the ministry. As I spoke many times on this, I find that ACP will play a role in countering lost opportunities in a society where no one talks about dying preferences, and give permission and even nudges to promote conversations that are initiated by HCP. As for the palliative care fraternity, they wanted ACP in because they wanted more conversation on the goals and values, and the ACP can be extended to other conversations such as goals of care when the patient is critically ill in the hospital. And by capturing those voices and choices made, they hope to see an expanded service coverage and establishment of step-down care centers. It will otherwise be unethical to actually discuss on ACP when options are severely limited. But as a group, we do see the potential limitation. As an ACP cannot predict all medical crises, the patients still are learning in the deciding for themselves, and that the wishes in the ACP may not be realistic. So there is also a concern that ACP may be wrongly activated when the patient still has a certain extent of capacity. So deep in our hearts, similar to published reports, we know that goals concordance, despite being the main aim of the program, may not be fully observed during the rollout, but at least the patient can still state their trusted family members or friends, and the patient and the family can be aware that death is possible and reprioritize and spending more time together. So bioethics do hope that to enable the right things to happen, to support the stakeholders and try their best to advocate for policy change. However, they have to come to terms feeling glad to be rightly engaged, over-engaged, sad to be over-dependent, or totally excluded from conversations. So they decided to make themselves visible, such as this. This is just one group. So the Malaysian Bioethics Committee, of which its members are now more occupied with their own ethics projects and duties, was formed during the COVID-19 to reach out to many clinicians on and also on topics such as vulnerable population, refugees, vaccines, ethics, and produce a 100-page guiding document that was freely available and downloaded more than 200 times. So as we know, we have to make friends. So there is a relationship between the ethicist and palliative care group, which is close for obvious reasons, and the things that we have done together, and in Malaysia, especially during COVID, continues to play a role in each other's lives. And we work in terms of training, writings, ethics committees, ethics consult, and advocacy. So when it comes to advocating the ACP program in Malaysia, the ethics and legal groups were engaged due to the ethical and legal issues surrounding the application of ACP that needed to be answered. What if a patient asks to end his life if he feels that it's no longer worth it? How should the doctors proceed if there's a conflict between what's best what the family wants and what has been documented. So I was fortunate to be able to contribute again as a clinician and to see that the system exists so all of us could say something about the care that we would like to receive as our lives come to an end. So some of us do want to avoid the ICU at all costs, a setting that feels very unnatural and cruel. And if it couldn't be dying at home for myself, surrounded by peace and love, at least I felt that I needed a huge window, light and space. So that was my personal agenda when I got myself involved in ACP. So I believe that kind of shared vision and drive brings more than over 70 clinicians over the 2 years together to plan for a program that was launched last year, September. And these guidelines covers the chapters on the goals, on some of the principles in decision-making, the ethical, legal, and social cultural consideration, specific disease considerations, communication skills, domestication, and palliative care steps at end of life. So in the proposed form, documentation form that different medical or surgical fraternities can adapt, you can see extra writing space to capture values and what gives a person's life the meaning, strength, and happiness, the concerns a person may have, and the type of care a person would accept or want to avoid, the preferred surrogate, and some areas that touches the preferences for resuscitation and life-sustaining treatment. So the program at this point is still at the stage of providers training, and that includes lectures and small group discussion on ethical justification of having an ACP, what are the legal and professional provisions, a refocus on the respect for person and the ethics point of view, and potential resolution if the stated past preferences in the ACP conflicts with the person's best interest or with the person's current preferences. So ladies and gentlemen, it's almost to end with my talk. And I will just now give you a peek into the content for number 6 to 8 about family roles and social cultural considerations in ACP to fulfill the theme of the symposium today. So as the guide wanted to make sure, as much as we hope a person can be free from external influences, especially our own family still plays a role in discussion and planning as part of understanding the patient and his or her reasons, and their responsibility to help fulfill those wishes with some guidance for clinicians conducting those discussions when they are faced with different capacity of family members. So we included some of the main religious traditions and information. Again, this is a general perspective, and it doesn't fit into what a person might feel about his own religion, such as Islam, of which a refusal of care can be honored, especially when treatment efficacy is questionable, and that perspectives and interpretation may still vary between schools and individuals. So I hope that there's no repetitive, sorry, Gerald, if there is repetition here, but we have decided we're going to repeat the important points. We also pointed out how even a self-proclaimed Buddhist may still be following very much cultural customs and traditions, and that a withdrawing of care can be acceptable when it does not fall under intentional killing. And most Buddhists will accept that death as part of the impermanence of life and wish for a mindful and peaceful end. So it is important that clinicians find the middle way to support patients and families through compassionate decisions. Okay. We include Christian perspectives on how the sanctity of life, the redemptive nature of suffering, role of pastoral care, and the incomparable value of every human person must be considered when managing a patient of Christian faith, and that even though burdensome care can bring distinctive meaning to Christian patients, but it's still something considered as extraordinary and not obligatory to partake. And when it comes to our patients, Mr. R, as a Hindu, the family opinion and their participation in decision-making was important as they fulfilled a duty for their closest family member, at least for one reason. Okay. As we closed the case, family conference was held. Mrs. R agreed as a family, Ali to remain as the family representative, and they would discuss as a family. They understood if his heart stops, cardiac compression would not be in his best interest. They wanted more time to decide otherwise on the next step. Nobody could ever tell what Mr. R would have wanted or his views on life-sustaining treatment. But the family did spend more time together in the general wards. So a documented or a known preference, would it have helped to allow medical teams and his family to know if the treatment still aligned to his goals and values? Would it allow Ellie to come to terms? So to conclude, ACP program in Malaysia stands as a commitment to persons and gives permission to talk about what matters to the person most. It incorporates the ethical consideration, legal provisions, families' roles, and social cultural aspects, which is very diverse in Malaysia. So further study is needed to evaluate the rollout of the program and how it may impact in-the-moment decisions and conversations between managing teams and patients and families. And Bioethics hopes to continue to advocate for better care and decision-making by bridging the values of professionals, community, and patients as what we see in the Malaysian ACP. So thank you very much.
Thank you very much, Dr. Tang. Our third speaker is Dr. Derrick, a clinical professional consultant, Honorary, CUHK Faculty of Medicine. He will be presenting on Confucian values as cultural lens in contemporary healthcare practices. May I invite Dr. Al?
Thank you. Thank you. I'm going to talk about Confucian values, but not in a philosophical way. Confucian values have gone through some difficult times in the past century, some really low times, but has made a very strong revival in the past few decades. This revival has multiple aspects and was not solely state-driven. So in contrast to what some people may think, it's not just because the government wants to have political legitimacy or something. It's very much also an intellectual drive and also a change in society. In a 2023 report from the Fairbanks Center for China Studies at Harvard, they discussed the appeal of Confucianism to modern China, and there are many reasons for its revival. I won't go into the details here, but just to say that the whole issue is much more rich than just one aspect of political or social. In bioethics, Professor Honorary Ping, based in the City University of Hong Kong, has for decades written extensively on why Confucianism and feminism should be taken seriously in healthcare of Chinese patients. And he is quite influential in mainland China and also perhaps also in East Asia. He's a sort of a champion and leader, arguing that we should have an Asian bioethics or even a specific Chinese bioethics. But I'm going to talk more in the context of healthcare practice, and that is how we can be culturally sensitive in the care of patients in Chinese societies, and whether Confucian values or the so-called Confucian lens is useful or helpful in the process of cultural sensitivity in healthcare practice. My thinking on this is influenced by late Professor Edwin Hui. He's a renowned ethicist and a scholar in Christianity and also Chinese culture based in North America. But he was seconded to the Hong Kong U after the millennium and has been a professor. And I think he remains the only professor in medical ethics in Hong Kong while he was here with us for about 8 years. I worked with him in the Hospital Authority Clinical Ethics Committee. I was chairman for some time there, and he is a very active member and very helpful in many ways. And we also became personal friends. He has written a book or a manual for clinicians in bioethics, and one of the chapters, one of the book chapters was talking about culture. This was for Canadian physicians. So he was talking about how Canadian physicians should be or could be handling better Chinese patients in Canada. Because he himself was a physician in the background, so he was not talking philosophically, he was talking really in practice, very down to earth, the points to note and what may help. And he provided a list of the essential quality of culturally sensitive and ethical communication for clinicians. And this include, among others, these points: assume diverse opinions, acknowledge potential differences in emotional expression, anticipate differences in conception of illness, where Taoist and Chinese medicine influences come to play, anticipate different views on informed consent and truth-telling. We heard quite a few discussions early today on truth-telling, involving the family, and noting that sometimes the so-called immediate family in Chinese families may include multi-generations. It's not just a spouse or the children. But note that he is not talking about mechanically and automatically accommodating all the values and beliefs of the Chinese patients and caregivers. He's talking about anticipate. He keeps saying we should anticipate the issues and be appreciative that this would be coming. This complexity will come into decision making. So he's talking about how to be aware of the cultural angle of the decision making, so as to make better communication and also to make better decision. And I thought he offered 3 very important insights, which are rarely touched by other authors on this subject. He shared that when you talk about Chinese patients or Chinese societies and Chinese culture, really be aware of demographics. And of course, again, he's talking in the context of Canada. When faced with so-called Chinese patients as a group, there would be Chinese patients from Taiwan. In the early years, it's mostly Taiwan. There will be from Hong Kong, from mainland China in the past few decades. And they are very different subcultures. And they are not the same. Chineseness is not the same among these groups. So he's saying that beware of the demographics. Traditional Chinese culture is not all Confucian. Seems to be self-evident, but sometimes it tends to be, the message tends to be lost when we keep saying that Chinese societies are Confucian societies. So Buddhist, Taoist, and philosophical Taoist, and also religious Taoist influence are often important in affecting values. And these beliefs, values, and attitudes are often blended and are often in transition. So it's transition to modern, from Chinese to Western, and it's certainly different in different generations of Canadian Chinese. So let's look at the Confucian lens. Some authors, actually quite a number of authors writing on the subject of Confucianism would start with a list of Confucian virtues. And there are many, many lists of Confucian virtues. The most popular list, I argue, would be these 4. In Cantonese, it's 三綱五常四維八德. It's almost like a poetic line. So it's the 3 cardinal bonds, 5 constant virtues, 4 cardinal principles, and 8 cardinal virtues. I'm going to let you have a few seconds to test your photographic memory, to see if you can memorize not all of them, but the similarities and differences of the list, because I'm going to make a few comments on this list. So these often in even academic papers, they often start with some lists and then talk about Chinese culture and then talk about what we should be aware of. But I have some problem with this approach, and I'll get into it in a minute. What actually are in the list? One of the list, the 4 cardinal principle is actually a pre-Confucian set of values. It's not Confucian. It's from Gunzong. I don't know the name in the translation in English. And of these 4, shame is actually a prominent virtue. Shame is quite an important part of Chinese culture in real life, but it's rarely talked about as virtues in literature. And it does affect healthcare practice quite a lot, especially in mental illness. One of the teachers in CHUHK actually just published a book talking about her family called Vivian Tam in the School of Journalism, published a book in talking about her family while in Canada, how the shame and Confucian family led to total enclosure of the issue within the family, not letting she as a sister of the mentally ill brother was not allowed over decades to mention to anyone that she has a brother with mental illness. And that has lots and lots of consequences. So eventually she was desperate. She went back to Hong Kong, and there was a crisis in Canada, and she flew to Canada and used emergent transport to take her brother to Hong Kong for care so she can take care of him. So now they're both in Hong Kong, and I met her brother. Recently, her brother is a very artistic person with schizophrenia. It's not private information because it's in the book. So a very, very moving story and very intense in many ways. Okay, I think the point is that some of these are sometimes missed in the literature, and two of the lists, the 3 and the 5, are really the core foundations in Confucian values. They're from Han Dynasty. Really, I think Confucianism becoming the cornerstone of social and political order in China is from Han Dynasty, because it's institutionalized and it's recognized. It's actually signed off by the emperor as sort of things to teach and also to disseminate. But the last one, which people sometimes talk about, we talk about filial piety. And filial piety only appears on the list of the last one, which is the 8 cardinal virtues. But this is a really modern one. Is actually one drawn up by Sun Yat-sen, a medical graduate in Hong Kong who became a revolutionary, overthrew the Qing dynasty and became the father of the new modern China in 1911. So this is so-called traditional emphasis on the emphasis on filial piety only appears on his list and nothing else. So it's quite interesting that when students sometimes talk about Confucianism, we talk about it as a sort of homogeneous sort of values. It's not quite that. And I think it's probably unhelpful if we treat Confucianism as a sort of hard deontological overriding principles. I always have problem when I read from authors to say, according to Confucianism, is this and that, and therefore we should handle a case like this. And I'm always wary of this kind of logic. But some people use a milder approach, and they use aphorisms and Confucian quotes to say that this is Chinese culture because Confucian said so, and everybody knows this is a saying that everyone knows, and use it as justification. I have trouble with that too. And I just give you one example. In organ donation, relatively low organ donation rate in Chinese society is common, quite low in Hong Kong. There's an active drive from the government, but still quite low. 4.7 per million people is really just 1/10 of the donation rates in Spain, so not doing very well. And often quoted cultural explanation is Confucian emphasis on preserving the body, quoting the book of filial piety, 身體髮膚受之父母不敢為傷. Every Chinese audience in the audience knows this by heart. And then say that therefore people would not like to donate their body because it's 身體髮膚受之父母不敢為傷. But of course, we know that preservation of the whole body is indeed a cultural preference. But is it the reluctance due to filial piety? I'm really hesitating to donate organ because I'm filial pious person. I don't want my father to be unhappy. I don't think that's anywhere near true. So I think the question is really whether any of these things are really relevant to the actual case and context. The other issue which I often have difficulty with, and I think Roger mentioned it in the morning, is that sometimes Confucianism is used as portrayed as an antithesis of individual autonomy. That's not just oversimplistic, it's also unhelpful. But in this kind of portrait, the family is often considered to be the starting point for the practice of benevolence. In some settings, the family is even considered to be collectively more important than individual patient's preference. And feminism is said to be highly regarded Confucian values that puts family at the center of importance, and because Confucianism is to be respected, therefore feminism is to be respected. This is in very simplified way, I think this is the argument. The Confucian feminism has some implications on informed consent. Involvement in medical consent is, of course, not unique to Chinese societies. I graduated from medical school in the States, and I did medical internship in Rhode Island, in Providence. And of course, we also involve families. There are Italian families, Jewish families, very, very familiar, very close ties within the family. So it's not unique to Chinese. But feminism, in the Confucian version, is a stronger view. It takes the strongest position that we should have family consent, or at least family-based consent. And it argues that the power to decide on health matters should rest with the family, not just the patient. The assumption is the family knows better than the patient on how to protect his or her best interest when he is ill and vulnerable. I just want to sort of end my thought on this with some observations on mainland China. Mainland China before 2002, the legal rule was that both the patient and his or relatives, even some non-family relevant persons, would be involved in the informed consent process. But in practice, often the patient was left out. Often they just talk to the family and get signed, and then go on with the surgery. With the new regulation, the new law, legal regulation in 2002, the legal norm is now to establish the duty established as a duty of medical staff to inform patients of their diagnosis, propose treatments, measures, and medical risks. This seems very basic, but it took 2003 for this to become the law, to say this is a must. This is a required part in the process, okay? You can engage the family, but this is the required process. But this didn't go really well because hospitals had lots of difficulty implementing it. And it was also a time when healthcare in China had a lot of so-called 医疗, that is violent response of families, unhappy families, even attacking doctors and nurses physically. So the law is there, but implementation is difficult. And some hospitals found their own way to, found their own ways to circumvent the issue. I was told one Shanghai hospital, the way they do it is when patient comes in the hospital, they first ask the patient to sign a consent to whether you want to have your family to speak on your behalf while you're ill. So once the patient signed that, then they can go on to just talk to the family as usual, right? But this is not ideal. So there's lots of discussions at the time on whether the law is too harsh or whether we should be more accommodating to the family. Professor Fang himself actually wrote some really quite important articles to argue that the law is not helping and that we should put more emphasis on respecting the family's culture. But further but the process did not slow down. Further legislation in 2010 actually now specifies that is the adult patient who is mentally competent, of course, is the only one that must provide legal informed consent. So we imagine China to be Confucian and so on, but China is moving on. So when I was listening to the Japan story, my question at heart was really, is the Japanese society and culture also moving on in some way? And I suspect it is, because I recently read a book by a Japanese pediatric cardiothoracic surgeon who worked in the Middle East, and then Lao Tianwo Gong went to Middle East and came back to Japan to become an advocate of truth-telling in end of life. And she wrote books, and she was a champion, and she was said to be quite influential in the field in that area. So last slide, so second last slide. In Hong Kong, my observation from clinical practice for some decades and then in hospital management, my observations on respecting autonomy and facilitating family involvement is that Hong Kong, of course, you know, we have a system of common law inherited from the British, and all the law is individual rights based. It's not family based. But in health practice, clinicians evolve professional ways to pragmatically include the family in the process, and to good effect in most cases. But they also adapt it to different situations. If you talk about informed consent, the patient consent is a must in the center. Families involved perhaps also as a supplement. In the Advanced Medical Directive in Hong Kong, we just legislated for Advanced Medical Directive in November last year. So we have an ordinance now on Advanced Medical Directive, which is, of course, individual based. And the ordinance does not say anything about the right of the family to be part of it. Okay, but then the Hong Kong Academy of Medicine issued a best practice guideline to suggest that advanced care planning is important, and in advanced care planning process, you involve the family. Okay, so we're using a professional approach to supplement the legal provision, which is individual based. But something which I have a little problem with is hospital discharge planning. I was a geriatrician in geriatric practice for many years, and we did a lot of hospital discharge planning. And my observation is that very often doctors would start the conversation with family first. So a patient had a hip fracture, still mentally competent, but the family may first talk to the wife or the children before talking to the patient about. And eventually the decision is not very often not reflecting the patient's wish. Of course, there are practical issues to consider, but sometimes I think there's the patient's wish and perspective could have been more involved in the process. So we are not, of the three, I think in Hong Kong, we are not yet finding the right balance in hospital discharge planning. We are too much for family decision making and too little patient involvement. But that's my observations. So I'm finishing up. I think in conclusion, my view is that Confucian values is a useful set of values to understand Chinese cultures and Chinese patients. But if you use it as a direct lens for cultural sensitivity issues, I have some problem with it. And I think it's more complicated than just saying respecting Confucian values. But at the end of the day, I think the question remains whether Confucianism is to be treated as a particular set of local traditional values to be respected because we respect diversity and pluralism. That is one way of saying it. Or is it going to be part of a global contemporary transcultural discourse in bioethics, which is a more dynamic, organic way of seeing the issues? And I think it's also more realistic. In Hong Kong now, 1/3 of the medical students in any cohort are from international schools, their children are expatriates, and they would be future doctors in Hong Kong. And people in Hong Kong move to other places and they move back. And mainland China, immigrants to Hong Kong comes in now to 1 million and 1.5 million. So it must be a dynamic process, not just because East meeting West is nice, but because in actual real world, they are mixing. So the perspective, the values are mixing. So if you want to be serious about cultural sensitivity, you need to be sensitive to the real patients, not the theoretical patients. So thank you for your attention.
Thank you, Dr. Au. So we'll now proceed to the panel discussion. That means it's time for us to have interactive discussion as well as thought-provoking questions from the floor. So to kickstart, we'll have the speakers to come up to the stage again. So may I now invite Mr. Lee, Dr. Tang, and Dr. Au, please. So I would also like to welcome the moderator of this session, Professor Roger Cheung, please.
Thank you very much for the very thought-provoking panel discussion. In the interest of time, I would actually like to invite questions from the floor first, so that you guys have a chance to raise your question. Pastor Low over there. Okay, so Pastor Low is actually former president or still president of the Christian Chaplaincy in Hong Kong Association.
Is not necessary. I would thank you, our first speaker, Mr. Lee, for sharing very meaningful and touching ministry experience from, as a Buddhist chaplain. I'm coming from a background as a Christian spiritual workers as an educator. We all agree that we try to appreciate our sacred teachings, no matter from Buddhists, Jesus, Taoism, or even Confucianism, to help respond to the spiritual needs of those who are involved in bioethical dynamics. So my question is, what do you think the biggest gap right now about integrating spiritual care in bioethical discussion, especially in our daily practice of medicine?
Sorry. Thank you for your question. I think in Hong Kong, the biggest challenge right now is the lack of collaborations between chaplains from different religion groups. Because of Hong Kong's colonial past, I think the Christian and the Christian chaplaincy unit and the Catholic pastoral service are a lot more well established compared to the Buddhist chaplaincy unit. So we have a lot to learn from both of the other two services. But I think if we could collaborate more, patients will benefit more because they will get more care. And in my experience, because we Buddhists we have no restrictions to care patients from other religious groups, whereas I think Christian chaplains might have difficulties caring for Buddhists or Confucius or Taoists who are currently suffering in the hospital setting. So I would hope that a kind person like you would be able to not only look after Christian patients, but also patients who are atheist, agnostic, Buddhist, Taoist, Muslim, Jewish, because as I mentioned in my talk, we are all one human family. So to me, there's no differences. Care is care. So so to me, to care is my service, regardless of who or where the patient comes from.
Thank you very much for your encouragement. Just share a good news for you, because I think the impression or the pictures that may is about 30 years ago, for those chaplains who only visit with the populations in the same religious traditions. And now, as I know, for example, the Christian group of chaplains who offered about 400,000 visitations to patients and families, whatever religious background that in the hospital we meet. So I appreciate the picture is changing and the concept is changing, but I agree with you, the cooperation, particularly the NGO types of spiritual care providers, how to integrate their contributions with the practice of medicine in the hospital structures. I think we have a long way to go. Thank you.
Thank you very much.
Wow.
Hello, I just want to thank Roger this excellent conference, and also for the three speakers. Mr. Lee, I want to thank you for bringing back the concept of compassion to bioethics, particularly in an age of AI. I think we need that, and I hope AI somehow in future will be able to develop compassion, and that I think would be something for bioethics to move forward. And I also want to thank Dr. Tang for your difficulty within a truly multicultural context to develop some kind of shared guidelines to promote end-of-life care. And I think the difficulty is immense, and I want to congratulate you. That's the second thing. And the third thing, I want to come to Dr. Derrick. Again, I want to thank you very much for your talk, because you're saying exactly the same important thing that I would like to say. If you want to start with Confucianism, start in the right way. I think a lot of the problems which you mentioned, which I fully agree, is a result of reading Confucian values, Confucian philosophy, just off the top of the sleeve and in a very superficial manner, and using them to justify whatever cause or whatever decision they want to make, without really understanding the core values of these virtues or whatever within a Confucian philosophy. And the reason I want to bring that in is because I think this center has the right potential to get us all to start relearning Confucian values. If we are serious about bringing in Confucianism to converse and dialogue with utilitarianism, with Kantianism, or with human rights theories in the modern world. Otherwise, we just forget about Confucianism altogether, because it's very bad what I heard. And I think you are absolutely right, they are non-starters. But the redeeming point here is our Japanese lady this morning, earlier this morning, her reference to Shimi and her reference to virtue ethics in Confucianism. Now that reminds us that virtue ethics is not just the monopoly of the Western world.
Right.
And it's not just Aristotelian. That could be a Confucian virtue ethics. But if you take those virtues out of context and read them as just some superficial value, you end up with what Derrick said and what we've been suffering, this generation of Chinese scholars who really want to spend our life reimagining, reinventing, reinterpreting, and re-understanding Confucianism for its rights and for its wrongs. I think, as you said, Derrick, it's very important for the next generation of medical students they all be well read and trained in Western theories, like Kantian philosophy, like human rights theories, like utilitarian moral theories. But why not Confucian or Buddhist moral theories? And not just values, and tell them these are the values. That's a non-starter. But I think your talk is so important and to be borne in mind if you are serious about Confucian ethics. And your point about balance and the doctrine of the mean has much more serious and deep interpretation than we just say, oh, just the mean, okay? And I want to thank you for the time and for this very excellent presentation.
Thank you, Dr. Tao. Thank you for the encouragement and the very profound comments. Derrick, do you like to respond to that?
No, that's very much appreciated. I think in response to what we could be doing in future, actually Roger and I and Anne have in the past year talked a lot about how we can sort of open up the issue of Chinese tradition, Chinese culture in the center, sort of culture and bioethics and Chinese culture and bioethics, because we think Hong Kong is really the right place to have enough substantial understanding of both modern and the classical teachings. And bear in mind, of course, in Chinese U, the Neo-Confucian philosophers were actually founders of one of the colleges in Science University, so we had that tradition as well. So we are really going to, we are really sort of on the verge of starting that, and you may consider my talk to be one of the first, how do you call it, menu taster. You know, there's a sort of taste menu of what we're going to be doing in the coming few years.
On the sign of actually some of the content of today's talks will be translated into textual format for a special issue that we are actually co-editing with Nancy Jecker for the Journal of Ethics and Medicine, and each of us are actually really contributing to this special issue, and will be again on the themes of how do we engage different cultures and traditions in the context of the shifting world order, global bioethics. So I think that is something that we should all look forward to. And we still have 4 minutes, right? So HS, I think your talk is very interesting. And you have talked about there is this gap between people wanting to die at home or places outside of hospitals, and that's their expectation and preferences, but the reality is quite different, and we also share that over here in Hong Kong. Actually, our number is a lot higher. The people dying at the hospital, it's over 90% in Hong Kong, but then according to a survey that we did, over 30% of people actually do want to die at home. So there is a huge gap between reality and preferences, and a lot of it has to do with what Derrick has just talked about, that idea of how do we kind of interpret the Confucian text of bodily integrity. So actually when we did our survey in Hong Kong, we found out that a lot of people are really concerned about dying at home, not only because of legal barrier, but also this social cultural barrier of bodily integrity. So they have this misconceived notion that if the person died at home, then they will actually be sent over to the coroner. Of course they will be, and then forensic pathologists will cut them open. So that would actually disrupt the bodily integrity. So they would rather move the body, kind of the scenario is kind of like, a lot of my interviewees would say, oh, grandma's dying. Okay, let's send her over to the hospital. Let's call 999 over here, not 911, 999. Get the ambulance to to bring her over to the emergency department, and then she can die over there. And also the morgue at the hospital is actually free of charge. So we have all these kinds of practical and cultural barriers to really match their preferences. Is that what you're also seeing over in Malaysia too? Like this cultural barrier, is it different contextually speaking? Yeah.
Yes, I think the one thing which is going to be similar to many countries is going to be that tension between a person and his family as well.
Uh-huh.
And the one thing that professional felt, there is quite a bit of challenges in imagining where the death can be, that everyone could accept, that everyone would have the capabilities to actually know what to do. So even it comes from the emergency physicians would be saying that the only place that the patient will end up when they are in a crisis will be at the ED, at the emergency department, and the only ethos that they have is to save lives. And the next thing would be, where should we put, a patient dying that wish to be left just with pain relief and whatever that fulfills his last wishes? There is no such place in the hospital. And the next question would be, where would that be? Because at home, it is equally a mess as well in Malaysia. So the one thing that if we were to be having a doctor in a family, somehow we know what to do.
Yeah.
So that also is not easy, because you have to get the drip in, you have to get the oxygen in, and you have to know how to manage pain and difficulty in breathing, and the last gasping, and it's just a challenging thing to do. And we don't have enough of community palliative physicians or nurses to actually go around. So what happened with ACP is just like something there that may actually move something in the whole system in terms of the community. It might be another thing about like putting in more money for palliative care programs, but somehow I think it is more of strategic kind of way to actually get people to talk about where they want to die. I think that is one thing that we keep on trying to make sure that bioethics play a role in being there, than saying, have you thought about this for yourself? Have you actually imagined what it would be like at the last moment of your lives? And we try to make sure that people have that moral imagination to get conversations starting.
I like how you use the word moral imagination. So, because, I have a colleague who's also a doctor, actually a very high official at the hospital authority before he retired. And his dad, a Buddhist, actually really wanted to die at home. But at the end, he couldn't do it. You know why? Because his family, his siblings who live elsewhere, not in Hong Kong, flying in from Canada and UK and US, all of a sudden they said, what we cannot afford to, care at the hospital for our dad. What's going on right now? So there are a lot of these tensions with the family that is really, really real. And I think part of the conversation today is to really try to figure out, okay, so how do we move forward? And how do bioethics education are going to help us in really imagining a future that is more ethical and ethically informed, and that is going to be the next topic that we're going to be engaged in bioethics education. So thank you very much, everybody.
Thank you.